Good afternoon, ladies and gentlemen. My name is Didier Locca. I'm an interventional cardiologist, and we will present this webinar together with my colleague Pierre Monney, cardiac imaging specialist. The topic of today's webinar is the role of advanced cardiac imaging in structural intervention, with the discussion illustrated by a TAVI procedure. First of all, the requirements in non-invasive imaging are greater for transcatheter valve intervention than for conventional heart surgery. During surgery, there is direct access to the heart structures, and the valve can be visually assessed by the surgeon with the diseased valve completely removed and the prosthesis of adequate size secured in place. Conversely, transcatheter intervention is performed from a remote access site, and therefore the most suitable access route has to be identified in order to plan the intervention, either vascular or through the apex. The size of the aortic annulus has to be measured non-invasively to select the right prosthesis size. The native calcified valve is not removed and is instead crushed between the prosthesis and the aortic root, and this results in a risk of annular lesion or coronary artery obstruction. In addition, there are several types of transcatheter prosthesis characterized by different profiles and anchoring mechanisms. The type of prosthesis should be selected according to the anatomy of each individual patient. Imaging of the peripheral arteries is required in selecting the most appropriate route: transfemoral, transsubclavian, transaortic, or transapical. Three-dimensional imaging of the ascending aorta and aortic root is mandatory, with precise measurement of the area and diameter of the aortic annulus, with measurement of the distance between the aortic annulus and the coronary artery ostia is crucial. In addition, a detailed assessment of the aortic root morphology, including calcium distribution and location, size, and angulation of the ascending aorta, or the presence of a prominent basal septal hypertrophy, will provide important information to help select the most appropriate prosthesis. This information is important for the heart team discussion and planning the intervention. The heart team mainly consists of an invasive cardiologist with expertise in TAVI implantation and a cardiac surgeon, but other clinicians involved in the management of patients with severe aortic stenosis are key partners, including cardiac anesthesiologist and geriatrician. As the TAVI procedure is a recognized treatment option for inoperable or high surgical risk patients with symptomatic aortic stenosis, the selection of the final treatment is essentially based on surgical risk assessment and criteria of inoperability. By adding an imaging specialist to the team, the specific aspect of the TAVI procedure can be taken into account in this discussion, including the feasibility based on annular dimension, the estimated risk of complications, the vascular access option, and the most suitable prosthesis type. The TAVI candidate is not simply a patient turned down for a conventional heart surgery, but a patient with anatomical characteristics that can predict a successful TAVI procedure. Conversely, if the anatomical characteristics identify high risk of complication, the surgical option can be reassessed by balancing the respective estimated risk of each procedure. However, the role of the imaging specialist is not simply limited to the heart team discussions. Their role is important throughout the patient's management, from the initial diagnosis to the follow-up after the procedure, and includes indication criteria for valve intervention, detailed anatomical description for heart team assessment, monitoring of the procedure, and the final results assessment after valve implantation. But do we need advanced imaging to assess TAVI patients? Most of the relevant information is obtained by using standard two-dimensional transthoracic or transesophageal echocardiography. However, for specific assessments, advanced cardiac imaging is required, either with echocardiography including exercise of the beta-menstrual echo, myocardial strain imaging, and 3D echocardiography or cardiac CT, which is key for assessing the aortic root anatomy and the peripheral vessel. Cardiac magnetic resonance imaging can also provide useful information in selected circumstances. Images obtained by this basic and advanced technique needs to be integrated by the cardiac imaging specialist to extract the relevant information for clinical decision and procedure management by the interventional cardiologist. In the specific setting of procedure monitoring, fusion imaging techniques may be of help to assist the interventional cardiologist by projecting three-dimensional cardiac CT or 3D echocardiography images onto fluoroscopic projection. To illustrate this concept, Dr. Monney will present a clinical case.
So good afternoon. This is the case of an 84-year-old lady referred with chest pain and exertional syncope in the context of known aortic stenosis. She has diabetes, hypertension, and high cholesterol, and her renal function is moderately reduced with an eGFR of 42 milliliters per minute. She has otherwise a good quality of life at home as assessed by the geriatrician. Initial transthoracic echo revealed left ventricular hypertrophy with normal systolic function and no regional wall motion abnormalities. The aortic valve was tricuspid with severe sclerosis and reduced opening. Doppler evaluation calculated an aortic valve area of 0.5 centimeters squared. The stroke volume was reduced to 32 mL per bead per square meter, with a mean transvalvular gradient of 45 millimeters of mercury, defining a low flow, high gradient aortic stenosis. Doppler evaluation also showed moderate mitral regurgitation with probable pulmonary hypertension. The coronary angiogram showed non-obstructed coronary arteries with right heart catheterization confirming pulmonary hypertension. Regarding the peripheral vessels, an angiography of the aorta and iliac vessels showed unobstructed vessels with minor tortuosity, which was confirmed by CT angiography. However, a severe 90% stenosis of the right internal carotid artery was diagnosed by Doppler. The aortic valve was moderately calcified on cardiac CT with little annular calcification. The mean annulus diameter was 22 millimeters and the annular area was 367 millimeters square. The distance from the annulus to both coronary arteries were above 10 millimeters, 12 and 14 respectively for the left and right coronary artery. On 3D transesophageal echo, the annular dimensions were identical to those obtained by CT with a mean diameter of 21.5 millimeters and an annular area of 368 millimeters square. A detailed assessment of the mitral valve graded the mitral regurgitation as moderate to severe, so higher than with the transthoracic echocardiogram. The regurgitation was functional with mitral annular dilatation.
The case was summarized as follows at the heart team meeting. Elderly patient with good quality of life, favorable geriatric evaluation, severe symptomatic aortic stenosis, class 3 renal failure, 90% stenosis of the right internal carotid artery, low risk for isolated IVR. But the combination of carotid artery surgery followed by surgical aortic valve replacement as the second step was considered too risky for this elderly patient, and a transcatheter approach was proposed. The results of the advanced imaging workup were summarized as follows. No complication for TAVI, main annulus diameter 22 mm, moderate valvular calcification, non-eccentric, few annular calcification, coronary artery distance more than 10 mm, no prominent basal septal hypertrophy, large unobstructed but calcified iliofemoral artery, more than 7 mm. The final decision was to implant the transfemoral 23 mm sapien prosthesis and to reassess the severity of mitral regurgitation at the end of the procedure. The procedure itself was performed under general anesthesia and monitored with transesophageal echocardiography as is routine at our institution. The valve was pre-inflated with an 18 mm balloon and the prosthesis placed through the native aortic valve. Several supraaortic injections were needed for right positioning of the prosthesis across the annulus before deployment. The patient became unstable and emergent deployment without rapid pacing was required due to hemodynamic instability. The blood pressure remained low after implantation. An immediate echocardiogram revealed a well-seated prosthesis with normal cusp function and only trace for a valvular leak. A pericardial effusion was rapidly ruled out,
but new severe global left ventricular systolic dysfunction was noted. We can notice that there was also complete loss of coaptation of the mitral leaflets on transgastric long axis view. Coronary artery patency was checked with good flow documented in the left main stem by Doppler. The right coronary artery was injected as it was not visualized by echo due to shadowing of the prosthesis. The Doppler assessment of the mitral valve confirmed severe mitral regurgitation with a complete loss of leaflet coaptation, as illustrated on the 3D reconstruction of the valve. The patient was clinically in pulmonary edema. In the absence of any cardiac lesion, left ventricular function rapidly improved after IV adrenaline, together with the mitral valve function, which completely normalized. The patient stabilized hemodynamically and was extubated few hours later. The acute left ventricular dysfunction was interpreted as secondary to the acute increase in afterload, when the undeployed prosthesis was placed into the very severely stenosed aortic valve. This dysfunction was completely reversible, as shown on the discharge transthoracic echocardiography. At the end of the case, so in the last section of this webinar, I want to summarize the role of imaging in the management of a TAVI patient, starting with the diagnostic phase. According to the current guidelines, severe aortic stenosis can be diagnosed when the following three conditions are met: a maximal transvalvular velocity greater than 4 meters per second, a mean transvalvular gradient greater than 40 millimeters of mercury, and an aortic valve area measured less than 1 centimeter square by continuity equation. This assessment has to be performed with normal blood pressure to avoid any influence of arterial afterload on gradients measurement. Basic assessment, of course, also includes the measurement of global and regional left ventricular function. Indeed, when left ventricular dysfunction is present, the stroke volume may be reduced, resulting into a low transvalvular gradient that is less than 40 millimeters of mercury, despite a calculated valve area less than 1 centimeter square. In this situation, it is important to differentiate between true severe stenosis and the so-called pseudostenosis, that is a sclerosed but still pliable valve that cannot be forced in open position due to weakness of the ejection flow. Advanced evaluation in this situation is made by dobutamine stress echocardiography, where the severity of the valve is reassessed under inotropic stimulation. If myocardial recovery occurs, true severe stenosis is characterized by an increase in transvalvular gradient, while the calculated valve area does not change. Conversely, the aortic cusp opening can be forced by increasing the stroke volume in case of a pseudo-severe aortic stenosis. In this situation, the gradients remain stable, while the calculated valve area increases above 1 centimeter square. According to the current literature, only true severe stenosis as diagnosed by low-dose dobutamine stress echo will benefit from valve replacement. Low-gradient aortic stenosis not only occurs with severe left ventricular dysfunction. This so-called paradoxical low-gradient aortic stenosis is associated with small hypertrophied ventricular and diastolic dysfunction, classically in elderly women. When associated with a reduced stroke volume, so-called paradoxical low-flow, low-gradient aortic stenosis, this hemodynamic type of aortic stenosis is associated with a poor prognosis without treatment. However, just as for patients with systolic dysfunction, it is crucial to distinguish severe from pseudo-severe stenosis in this setting of low-flow state. To make this distinction, dobutamine stress echocardiography has been proposed, but the safety of an inotropic stimulation of small hyperdynamic left ventricle has still to be documented. Another approach is based on the degree of valvular calcification, as a correlation has been reported between the valve weight, amount of the valvular calcium, and stenosis severity. Registry data has proposed to use the CT Agatston score with a cutoff value of 2,000 units in male and 1,200 units in female to diagnose severe stenosis or to help diagnosing it. Once stenosis severity has been proven, should the valve be replaced? The main indication for valve replacement are symptoms and left ventricular dysfunction. LV dysfunction with an ejection fraction cutoff value of 50% can routinely be assessed by 2D echocardiography, 3D echo, or cardiac magnetic resonance. Myocardial strain imaging by speckle tracking echocardiography demonstrated the presence of a subclinical LV dysfunction in patients with aortic stenosis and normal ejection fraction, which was proportional to the stenosis severity, suggesting that markers such as global longitudinal strain could be more sensitive markers of LV dysfunction in the context of aortic stenosis. Moreover, a reduction in longitudinal myocardial function has been correlated with the amount of myocardial fibrosis and with a reduced functional improvement after valve replacement. Myocardial fibrosis could become a valuable prognostic marker that can be easily measured by cardiac magnetic resonance imaging using late gadolinium enhancement and T1 mapping sequences. Important information regarding the technical feasibility of TAVI procedure are provided by advanced imaging. Vascular anatomy is important to decide the best access route for the transcatheter procedure, transfemoral, transsubclavian, transaortic, or transapical. Peripheral arteries can be evaluated with conventional angiography or preferably with CT angiography. The minimal arterial diameters should be greater than 6 mm for most available delivery catheters, but larger diameters have to be considered in the case of circumferential vascular calcification. Severe tortuosity of the arteries may be limiting. For patients with severe renal failure, aortoiliac Doppler ultrasound can be used to rule out a severe vascular stenosis. Annulus measurement is crucial for the TAVI procedure as it will determine the feasibility of the procedure and the selection of the prosthesis size. Selecting a too large prosthesis is associated with a risk of annular rupture, whereas a too small prosthesis can result in a higher risk of significant paravalvular leak after implantation. As the annulus is an oval-shaped structure, 3D imaging is mandatory for a correct transfixication. The measurement plane is at the hinge point of the cusps, and the maximal and minimal diameters, the area, and the circumference are measured. It is still unclear which of these measurements is the most relevant to measure to base our decision from a prognostic point of view. A control study has suggested the sizing algorithm based on the annular area measured by CT, where the prosthesis was oversized by 5 to 10%. The use of this algorithm resulted in a reduction of paravalvular leak implantation. 3D echocardiography appears to have an equivalent accuracy to CT to predict the occurrence of paravalvular leak and is used in several centers, including ours. Both 3D methods are successfully used to assess the annulus to coronary artery distance. A distance greater than 10 to 12 millimeters is important to document to reduce the risk of coronary occlusion by the native valve calcification during prosthesis implantation. Several types of prostheses are on the market and all have different specificities. Self-expandable versus balloon expandable, with or without interaction with the ascending aorta, annular versus supraannular valve, self-centering or not, repositionable or not, with or without ceiling skirt. A detailed morphological assessment is therefore of great importance to select the most adapted prosthesis type. Important features to report are a basal septal hypertrophy, the presence of a horizontal aorta, a dilated ascending aorta, or conversely a very small sinus valsalva, the presence of bulky or asymmetric calcifications, or a bicuspid aortic valve. Most of this information is obtained with a detailed basic 2D echocardiography. Finally, we routinely use transesophageal echo monitoring during the procedure. TEE can guide the apical puncture and transapical approach by simple biplane imaging of the apex. The transesophageal echo can help to position the undeployed prosthesis across the annulus, after this step is mainly performed under fluoroscopic guidance only. In case of hemodynamic instability, having a TEE probe in place is of great value, as it can immediately assess the cause of instability and efficiently guide further management. important causes of hemodynamic instability during TAVI include pericardial effusion following annular rupture or myocardial perforation, acute left ventricular failure secondary to coronary artery occlusion, or acute afterload mismatch, as in our case, acute mitral regurgitation related to traction on the subvalvular apparatus by the stiff guide wire or direct caudal injury, severe paravalvular leak caused by a bulky calcification, or an inadequate positioning too high or too low of the prosthesis, and finally, valve migration. The final result after implantation should be assessed with echocardiography, either transthoracic or transesophageal. Our checklist includes the position of the transcatheter heart valve, the cusp function, the grading of the paravalvular leak, the LV function, the mitral valve function, the presence or absence of pericardial effusion, and the integrity of the aorta. And we usually perform an angiography of the iliac and femoral vessel to check any lesion related to the vascular access. We favor the use of transesophageal monitoring during TAVI procedure at our institution, as it provides continuous high-quality monitoring throughout the procedure. It is particularly useful in cases of hemodynamic instability, and it often provides better imaging quality for final result assessment and transthoracic echocardiography. It can be of importance for detection and grading of a residual paravalvular leak. Finally, the presence of the 3D probe allows fusion imaging with fluoroscopy, which may be valuable for complex structural interventions. The downside of TE monitoring is the need for general anesthesia during the procedure. This is associated with increased procedure times, additional costs, and potentially a limited availability of the anesthesia team. TE is associated also with a small risk of esophageal injury.
Our take-home message for this webinar are the following. Imaging is key at each step for structural heart interventions. Cardiac imaging is becoming more multimodal, including fusion imaging and needs really integration. Non-invasive cardiologists should be fully involved in the heart team discussions. Collaboration between imager and interventional cardiologist is a key partnership through the procedure. We take the opportunity of this webinar to advertise the 6th Advanced Cardiac Imaging course for interventional cardiology, which will take place at the New Barts in central London on June 25th. This is a joint course between the Barts, NHS Queen Mary University, Lausanne University Hospital, and the Mayo Clinic. So everyone interested in imaging during structural intervention, please come along and book the date. We will finish by thanking all our colleagues, the cardiology team and department at Lausanne University Hospital and the London Chest and Barts who take part to our structural intervention program, and we want also to thank you for your attention.